Good evening, everyone. On behalf of Naidoo Pharmaceuticals, I'd like to welcome you to the first engagement meeting with the physiotherapists of South Africa. My name is Adele Bale, and I'm responsible for the musculoskeletal portfolio at Naidoo Pharmaceuticals. A special thank you to my colleague Ruben, who spearheaded this initiative alongside Dr. Ruben since last year. I'm honored to be taking it forward from here. This event will be recorded and made available for you to watch again at your leisure. The link to the recording will be added to the same platform where you will complete the CPD questions in order to receive your 2 CPD points. The link and QR code to tonight's event has been posted in the chat box and will also be shown on the last slide of the presentation. If you lose signal, as we do have a bit of rain in Gauteng tonight, please rejoin the webinar via the Zoom link as quickly as possible to avoid missing out any important information. Please feel free to ask questions during the Q&A question session. You can post your questions in the chat box and we will ask the questions on your behalf at the end of the session. With the commencement of the Protection of Personal Information Act 4 of 2013, which recently came into effect in South Africa, we would like to take the request that no personal information such as patient names, etc. are used when asking questions during the webinar. Please also refrain from using company names or medicine trade names. If this inadvertently occurs, it will be edited out of the recording of the webinar. Please note that if you post a question or comment in the chat box, your question and comment together with your name will be visible to all participants and will form part of the recording. Therefore, should you have any questions but do not want to participate during the webinar, these may be sent to us via email after the recorded event. And that brings us to the introduction of our speakers for the evening. Dr. Ruben Naidoo is a specialist anesthesiologist with a passion for the management of patients with chronic pain disorders. He provides a chronic pain service based at Morningside Mediclinic and work in conjunction with both the MDT of the East Rand Multi-Speciality Oncology Board and the allied professionals with MH&P Pain Matters Clinic in Sandton. He strongly believes that by combining the work of an interdisciplinary team with pharmacological and interventional procedures, we can augment the outcome from physical exercise and patient neuroscience education, together enhancing and remolding neuronal plasticity, thereby helping to improve the way patients live with chronic pain. And it is this strong passion which brought us together tonight. Dr. Ruben, it is my greatest pleasure to start this journey tonight, and I'm thankful for you reaching out to us, with tonight being the first of many engagements making this interdisciplinary team vision a reality. Our second speaker for the evening will be Laeeqa Sujee, who is a motivated individual with a strong desire to improve the health status and quality of life of South Africans. She has 7 years of experience in the field of clinical physiotherapy and 6 years of experience in the field of education of physiotherapy students. Laeeqa has a BC in physiotherapy, a postgraduate diploma in interdisciplinary pain management, and a Master of Public Health in the field of social and behavior change communication, with a long list of awards rewarded to her during her study years. This is already a mouthful, but not all. She's currently also a PhD candidate at the University of the Witwatersrand. Laeeqa, we are privileged to have you with us tonight. And with this, I'm handing the floor over to the 2 speakers.
Thank you very much, Adele. Good evening, everybody.
Good evening, everyone. Thank you so much for joining us, especially on an Thursday evening after a long work day. We're hoping that this presentation will provide you a little bit of insight into the pharmacological management of muscle spasms and an understanding of the physiotherapy implications for it. So as mentioned, I'm Laeeqa, and this is Dr. Ruben Naidoo, and we are going to commence.
Laeeqa is just as Adele mentioned, is a physiotherapist who specializes in chronic pain along with lots of other specialties, and I'm a specialist anesthesiologist and chronic pain specialist. And with every presentation, we must make declarations of that are pertinent to this presentation. And we are very thankful for Innova for sponsoring this presentation. We have also been privileged to receive an honorarium from them for this presentation. We must emphasize that the contents of this presentation has been extensively researched with an extensive reference list. And should anybody wish to have this reference list, please just drop us an email at this email address, and we'll happily send it across with any of the articles that we have on record.
Okay, so this presentation is going to include a quick patient story just to provide a bit of context and a bit of an understanding of physiotherapists and what we experience in a day-to-day. We're going to go through a simple physiology of muscle contraction, classification of muscle relaxants, individual drug discussions, multimodal analgesia, and then lastly, practical implications for physiotherapists. So this is a typical patient that we may see in any of our clinics. So Mr. S is a 44-year-old male. He is married and he has 2 children. He is a CEO of a finance company. He's extremely stressed, extremely busy, extremely overwhelmed. He started experiencing neck pain with referred pain to both his arms as well as headaches and slight lightheadedness. As a result, he went to his doctor who prescribed some medication and had imaging done. Imaging showed that he had degenerative changes from C4 to C7. The doctor prescribed various medications and told him to go to physio for muscle release and tension release. He comes to you and he has the following questions. So he believes that taking medication will decrease his pain, and together with massage, he will be fine. He tells you he cannot remember the names of the medication, but when he goes home, he'll take a picture and send it to you. He knows that he was given muscle relaxants. He says that he takes them as he needs, and currently he's taking about 6 a day. You try your best to explain physio to him and what you're going to help him with and your various techniques, but all of his questions are around medication.
Oh, Laeeqa, tell me, I'm so scared. How many medicines can I take before I get addicted? Oh, and before food or after food? Can I eat it with curry? And should I be taking it before I come to your session? I really need it afterwards, because that's when the most pain is. Tell me, Laeeqa, tell me.
So I'm hoping most of your patients aren't as dramatic as Dr. Ruben Naidoo over here, but with a raise of hands, how many of you felt that this was a bit relatable, that you had questions around medication that you could not answer? So please give me a raise of hands. There we go. How many of you, raise your hands, have felt overwhelmed when asked about questions related to symptoms of muscle relaxants, or side effects of muscle relaxants? Okay. How many of you feel that you're just not sure if it's ethical for you to answer these questions, if it's ethical for you to say, take enough energy in afterwards? And how many of you feel that we don't know enough about side effects to understand physio-practical implications?
So I think the important thing here is to understand that the world is rapidly progressing to alleviate the burden of the ratio of prescribing doctors to patients. In the UK, as far as the early 2000s, physiotherapists have had prescribing rights if they applied for it and underwent special training. These are called independent prescribers rather than a medical practitioner prescriber, and they even allowed to prescribe 7 scheduled drugs, including morphine, fentanyl, and diazepam. In Australia, there's been active work by the Physiotherapy Association to endorse physiotherapists to become autonomous prescribers, so much so that the latest application has gone through at the end of last year. And watch the space. In the next year or two, the Australian Physiotherapy Society will have prescribing rights. In South Africa, the South African Journal of Physiotherapy made an interesting publication in 2023 where they ascertained the attitude to medicine prescription amongst physiotherapists. And there was an overwhelming 87% response that answered from about 360 participants saying that yes, physiotherapists should be prescribers And there were similarly over 87% who said that they would be eager to undergo prescription training in order to fulfill this duty with diligence, insight, and intuition. But like anything in science, we cannot understand complex issues without going back to the building blocks. So we're going to try to avoid any post-traumatic stress disorders from all of you in your first and second year physiology, and hopefully try to make this neuromuscular junction seem a bit exciting, because this is where muscle contraction originates from. In the presynaptic cleft, an action potential arises, and this action potential within the distal presynaptic neuron causes a massive activation of calcium channels, resulting in an influx of calcium into this presynaptic terminal end. This rise in calcium facilitates vesicles that contain the neurotransmitter acetylcholine to be expelled towards the edge of this presynaptic cleft, dispelling these little acetylcholine molecules all over the intersynaptic cleft. On the postsynaptic cleft, there are multiple receptors for the acetylcholine molecule, acetylcholine receptors, which are sodium channels. And as the acetylcholine sits on these receptors, it opens the sodium channels, causes a massive influx of sodium, creating a new action potential in the actual muscle. This newly generated sodium-mediated action potential contributes to the opening of L-type calcium channels in the sarcolemma of the muscle cell. And this results in the opening of this receptor, which then causes an influx of calcium. But this calcium entry is not enough to facilitate muscle contraction. It is a precursor that stimulates, so this calcium stimulates the ryanodine receptor located on the sarcoplasmic reticulum membrane, which is also a calcium channel. And once this ryanodine receptor opens, there is a massive expulsion of calcium into the sarcoplasm of the muscle. This calcium then goes and binds to the troponin complex, which results in a shifting of the pink fibrous band here, which represents the tropomyosin molecule. And as the tropomyosin shifts upwards, it opens an activation point on actin, whereby the myosin head can then attach and facilitate a contraction between the actin and myosin filaments. And that is how we end up with a physical muscle contraction. It's my favorite topic, so I've added a little a mini picture here. Magnesium is an interesting component, which we'll speak about a bit later, where it directly acts as a calcium channel blocker. But a little more on that later. In South Africa in 1965, the government passed the Medicines and Related Substances Act, colloquially called the Medicines Act. And it's this act that determines who can have access to what drug and who needs to prescribe what drug. And it's divided into 9 subsections from 0 schedule to Schedule 8. 0 is the stuff we find over the counter in our grocery stores. It's those stuff that we can get from the petrol stations at 2 in the morning when you're out. And then we get Schedule 1 and 2 drugs, which are only available over a pharmacy counter. So they have to be sold in the presence of control by a pharmacist. And these include drugs like antibacterial creams and cold and cough medications. Schedule 3 to Schedule 6 requires a prescription. In these prescription-mediated drugs, Schedule 3 and 4 are drugs that you can actually send a virtual script from your phone to the pharmacist. Schedule 5 and 6 drugs are a bit more complicated because Schedule 5 drugs are a lot of the sedatives, the sleeping medicine, the tranquilizers, the antidepressants, and Schedule 6 drugs are a lot of these strong opioid narcotic painkillers, and included here is tetrahydrocannabinol. And Schedule 5 drugs need either the original script or a copy of the script being received directly from the doctor's email address that the script is registered to. Schedule 6 drugs require the actual ink script, so no virtual scripts can be received. Schedule 3 to 5 are allowed a 6-month repeat on each script, but Schedule 6 drugs require a new assessment being made by the clinician each month to validate the need for such heavy scheduled medication. Schedule 7 and 8 are somewhat of the illegal substances and include drugs such as heroin, mandrax, and the amphetamines. Today, we're going to be looking at skeletal muscle drugs because as physiotherapists, I'm sure skeletal muscle issues are a major component of your practice. And there are multiple classification techniques, classification systems that are available. And this is one that does it anatomically by looking at peripheral acting drugs and centrally acting drugs.
But when the peripherally acting ones, those names look a bit strange. Who prescribes those and when are they prescribed?
Well, they look strange because these are drugs that are only used by an anesthesiologist. Peripherally acting drugs physically work at the neuromuscular junction. And can you imagine the neurosurgeon busy doing surgery on the brain and the patient asleep, but not paralyzed, and the patient decides to cough? I mean, that's an oopsie you don't really want to have in theater, hey. So it's very important in such intricate surgeries that we paralyze a patient so that the surgeon has the best surgical access to perform the best surgical procedure. So we are not going to be discussing any of these because these are quite highly specialized drugs. We are going to be focusing on the centrally acting drugs this evening. Centrally acting drugs are a pharmacologically diverse category of medications that include antispastic and antispasmodic medications. And some of the examples that we're going to be discussing today are baclofen, the benzodiazepines, cyclobenzaprine, metocarbamol, and ephedrine. Unfortunately, centrally acting drugs have a few adverse effects.
Can you describe some of this? You're saying central nervous system adverse effects. As physios, what are the type of implications that we should be looking for here?
I suppose the big thing underneath of the central nervous system is either you're awake or asleep. So most of these drugs actually induce severe levels of somnolence, sedation, which you'll see a bit later on how, particularly in the elderly patients, falling because of the somnolence sedation is a major, major risk factor. But we'll explore this a little later. It's important that we know that these central nervous system actions relieve muscle spasms, but do not actually have a direct effect on the neuromuscular junction or the actual muscle. So this is a classification that I process in my mind that helps me based on receptor activation. And we're going to discuss a little about what GABA is and what an agonist is in the next slide. But classic examples of GABA agonist drugs is anesthesia, because GABA is a neurotransmitter that makes you sleepy, and that's what anesthesia does. And a drug that works that's available orally is baclofen. The benzodiazepines are a massive range of drug options, and these are some of the most common ones. Due to regulatory authority, we cannot actually tell you the names of the trade names. But during the course of this presentation, I invite you to access your search engine on your computer. And as we talk about the drugs, please consider looking up some of the common trade names because these are what you and your patient will encounter on a daily basis.
I can assure you that these names may look a little bit confusing to you, but a lot of these medications you actually know. You just may know it by the trade name or the name that the patient has given you. So really take this opportunity to do a quick Google search if it is confusing you a little bit.
And it doesn't matter if you don't like lamb or if you don't like your Auntie Pam, they still work. The centrally acting alpha-2 agonists work on the central nervous system's autonomic system and the alpha receptors. Unfortunately, tizanidine is not available in the country, but I've included it here for your own reference because quite a lot of the research has been done in the last 15 years on tizanidine. So one should consider reading it up for your leisure or academic insight. We will not be talking about clonidine in today's discussion because the literature on muscle relaxation is quite limited, but it is considered in situations where patients have tried all other drugs. A large part of our discussion today is going to be focused on the anticholinergics, because many of these are readily available over the counter and accessible by prescription in our country. The drugs that we are not going to discuss, and it's important because a lot of you will ask about them, and the reason why we're not talking about them is because they indirectly contribute to muscle relaxation. Think about it. When your muscle is tight and in spasm, you're going to have an inflammatory mediated soup response. So that is why a lot of times anti-inflammatory drugs are used in conjunction with muscle relaxants to alleviate the contributing side effect from spasm. We will not be discussing any of the opioid-based analgesias, nor will we be discussing any of the pure analgesics, including paracetamol. And again, we will not be discussing injectable drugs like botulinum toxin. There are a whole lot of drugs that are not available, but if you do search the literature, you will come across them. Interestingly enough, if you are never certain whether drugs are available, the South African Pharmaceutical Health Regulatory Authority has a beautiful website where one can actually type in the drugs and find out all brands available in the country. So by all means, please make use of SAHPRA's reference website.
Okay, so with any medication, there are contraindications. You'll notice on each slide, when we're speaking about various medications, we're going to put pregnancy category A to D. It's important for you to understand what we mean by these categories. So category A means that there's no risk in human studies for people who are pregnant. Category B, no risk in animal studies. Category C, the risk cannot be ruled out. Category D, there's evidence of risk. And category X, it is contraindicated. I suggest that you quickly take a picture of this, because as we go through the slides, we'll just see category A. So it will just give you an indication of the pregnancy risk.
One cannot talk about centrally acting drugs when one doesn't appreciate the value of this beautiful neurotransmitter called gamma-aminobutyric acid, or colloquially called GABA. GABA is one of the inhibitory neurotransmitters, along with a particle called glycine. And essentially, to make it a simple understanding, it actually blocks cell activity. So by blocking cell activity, there's no action potential generated, and essentially it just causes rest and sleep. And the words agonist and antagonist are pharmacological terms which make reference to how a molecule attacks the receptor. An agonist means it positively activates the receptor to do what the receptor should be doing, and an antagonist means it blocks the action of the receptor. When understanding muscle relaxants, a good classification and a commonly encountered classification is the division of these drugs into antispasmodic versus antispastic. So a simple way to think about antispastic or spasticity is pathology mediated through upper motor neuron pathology. So anything that involves a block that facilitates the reflex arc to constantly recycle itself. So think about the physiology of the reflex arc doing this, and what are the symptoms that it manifests? Hypertonicity, hyperreflexia, stiffness. And some of the common causes of central mediated spasticity include conditions like multiple sclerosis, cerebral palsy, spinal cord injury, brain injury, and post-stroke syndrome. The drugs that work here include baclofen and the benzodiazepines. Spasm, on the other hand, can be considered almost like a lower motor neuron pathology, peripheral pathology that even includes conditions that involve muscle sprain and injury and peripheral nerve damage. And the symptoms here are usually associated with jerking responses, twitches, and cramps. And the conditions or causes of these include a non-specific array of musculoskeletal pain, fibromyalgia, mechanical lower back pain, and herniated discs and myofascial pain. And these are commonly the drugs that I have classified under the anticholinergics, but those include the methocarbamol, the cyclobenzaprine, and orphanedrine. Interestingly enough, the benzodiazepines are the only drug that are considered mixed antispasmodic and antispastic. So understanding the value of benzodiazepines, I decided to start with the benzodiazepines. And these are Schedule 5 drugs, so they require an original script and or a digital script from the practitioner's email address. These are drugs that are commonly prescribed both in hospital and out of hospital. This is what I use the short-acting agents for when you're coming to theater, and I give you a pre-med to take away your anxiety. It serves as an anxiolysis. These drugs are broken down by the liver and are excreted by the kidneys. And the mechanism of action in muscle relaxation is still to today relatively unknown. But because benzos have a direct effect on the GABA particle, one considers that the inhibitory agonist activity plays a role in muscle relaxation. And it's a pregnancy category D.
When is this drug chosen, a benzo?
Well, the indications are multifold, and you will probably see all your patients coming with their buckets of sleeping pills. They'll be on alprazolam, on clonazepam, on lorazepam, and so most of the indications that you probably will find are for sleeping or insomnia conditions. The other registered indications include status epilepticus, an induction of amnesia. So if you're coming for an awake procedure, I will give you a tickle of a benzo. So you'll be awake when I'm doing my whole pain intervention. But when you leave the theater, you have no recollection of that. So this sounds familiar, hey? For those of you who go into a nightclub and you're watching your drinks, this is what you should be protecting your drink against, having a benzodiazepine dropped into the drink. They also indicated in spastic and seizure disorders and are the treatment of choice in acute alcohol withdrawal. Some of the terrible side effects include they make you very sleepy. They also cause a reduction in the respiratory rate. So you should be careful if you're using it, particularly in your patients with a large BMI, because what happens is that they take this as a sleeping pill and then they go to bed and they become apneic through the night and they develop obstructive sleep apnea and they raise their right ventricular strain because they have pulmonary hypoxic vasoconstriction, and it just facilitates a sequence of metabolic syndrome risk factors. So be very wary in the very obese patients. And if you come across in your practice a patient with all these sleeping pills who are obese, just educate them a little about how they are worsening their hypothalamo-pituitary axis by being on it.
So how long can you be on a benzodiazepine for?
Well, this is the problem. Benzodiazepines actually work on a type of receptor called metabotropic receptors. And the more metabotropic receptor gets stimulated by a benzodiazepine drug, the more it decides to go and hide. I always tell the male patients that when their wives are talking, they eventually switch off and they stop listening to their wives. And that's essentially what the benzodiazepine receptor does. It goes and just ignores the drug. So essentially you develop something called tolerance, where you need more of the drug to get the same effect. So we shouldn't be taking these drugs without having what we call benzodiazepine holidays, where for a few weeks we change them to another type of drug, which we'll talk about a few options coming on.
I think this is really noted with lorazepam because patients who really are using it for agitation and anxiety, they often increase the dosage by themselves. And they'll tell you, I'm going to take a lorazepam tonight so that I can sleep better because I'm going to have a busy day and my head is quite busy. How do you suggest we respond to those type of questions?
It's a bit of a problem because I would write a script and say 30 tablets. But the problem is I'm writing a script for 30 tablets. My neighbor next door down the road is also writing the same script for the same patient for 30 tablets. So there's no central regulatory system in the country where we are logging on Schedule 5 or 6 drugs as to how many patients are getting from different practitioners. So it's a system error. So you can educate as much as you can, but the problem is that benzodiazepines offer sleep, and patients sometimes are so desperate for that they're prepared to try anything. So one of the things to worry about is that an overdose of benzodiazepines often mimic alcohol intoxication because because alcohol acts on benzodiazepine receptors as well. So if you come across this, remember that there is an antidote called flumazenil and one should adopt basic life support algorithms. Hello, hazards, help, airway, breathing, circulation. We're going to move on to baclofen. And baclofen is approved by the Food and Drug the Food and Drug Agency of the United States for managing reversible spasticity. And it's particularly effective in relieving flexospasms, clonus, and these associated pains. Patients with spinal cord lesions and multiple sclerosis also have been proven to have beneficial effects from baclofen, and it is the only drug that is approved for intrathecal administration in managing muscle spasticity from cerebral conditions in the above 12-year age bracket. So think about all your adult cerebral palsy patients or your teenager cerebral palsy patients. When they get to a maximum dose of oral baclofen and they're getting partial response, one should consider intrathecal administration of the drug. But because baclofen is a GABA agonist, the side effects again are sedation, confusion, weakness. And interesting to know is that in patients with Parkinson's and post-stroke, there's a lack of reassuring evidence as to the benefit of it. So we should be erring on the side of caution. But remember that a lot of these times, Parkinson's and post-stroke patients have a multiplicity of other comorbidities that have to be considered. Like I mentioned, baclofen is a GABA agonist. It's a pregnancy category C. And why baclofen is interesting is because there's lots of work that's come out in the effect that baclofen has on neuroprotection. And essentially, a classic example would be in rat studies. They give one rat baclofen and they don't give the other rat baclofen. And in both the studies, for those of you who are a bit squeezy, you can close your ears now. They block the carotid arteries and they induce a stroke in both the rats. And the rat that did not have the baclofen would have had a big stroke, and the rat that didn't have the baclofen would have had a smaller stroke. So that they presume that the baclofen has some ability to protect organs from traumatic events. Baclofen is also being extensively researched in its intrathecal application in the under 12-year age bracket. And a lot of times, patients under 12 are receiving intrathecal baclofen and having a good response. And if you watch this space, I'm sure in the next few years, there will be advances to include it in its approval for use intrathecally. Interesting to note is that the effect of baclofen is not only dose dependent, the dose can impact on the severity of spasticity will determine the dose that is needed, which will determine the duration of action. So the more severe the spasticity, the bigger the dose that can be used that could facilitate a longer duration of action. Moving on to the anticholinergics, these are drugs that work particularly by blocking acetylcholine at the cholinergic receptor. These receptors are found all over the body, including organs like the heart and the lung and the brain. And essentially, they work by blocking two receptors, the nicotinic receptor, which is located at the neuromuscular junction and all over the nervous system, and they block the muscarinic receptor, which is not only found in the nervous system, but also found in exocrine glands and smooth muscles of the lung, in the womb, and in the heart. And the side effects of these drugs are all very much similar, including sedation, urinary retention, and the dry mouth has to be one of the most common side effects of the drugs in this class. We're going to talk about orphenadrine. Orphenadrine is a Schedule II drug, so it's available in pharmacies over the counter, and it's predominantly used to treat back pain and muscle spasms. It's occasionally used to manage patients with Parkinson's-induced tremors, and orphenadrine is the only one in this group of drugs that are available in combination with paracetamol, which means that it has useful beneficial effects on both fever and there's suggestions that it is used off-label for menstrual pain. Important to note is that the contraindications of precautionary use includes patients with the eye condition glaucoma, gastric obstruction, prostatism, myasthenia gravis, and that this is a pregnancy category C. When orphenadrine is combined with paracetamol, They offer effective relief for lower back pain, disc herniation, torticollis, and for trauma conditions associated with whiplash injury and sprains and strains. Very often, its sedentary side effect is used by some people here when they go to bed. This article comes out of a great publication by Smith in Essential Pain Pharmacology textbook. And it actually talks about how orphanedrine works. And the beauty of orphanedrine is that it not only works on the muscarinic acetylcholine receptors by blocking them, it has antihistamine properties. It works on the NMDA receptor as an antagonist, very much similar to the drug called ketamine. And it does prevent the reuptake of noradrenaline in the synaptic cleft. It also helps by blocking sodium channels. So it works on multiple locations, including having central nociceptive properties. It comes in an oral form, and the beauty is that it can be administered twice daily because it can last in the extended release form up to 12 hours. When one ingests it, one will get an effect within 30 minutes of ingestion. So it's quick acting with a long duration of action. Metocarbamol is also a Schedule II drug, therefore available over the counter. And this has also been on the market, similar to orphanedrine since the late 1950s. Metocarbamol is an antispasmodic agent used to treat involuntary skeletal muscle spasms. And it differentiates from the antispastic agents because it specifically it does not address spasticity from upper motor neuron pathology. The mechanism of metocarbamol's action remains somewhat uncertain 60 years later in its use, but there's some theories that it does have some calcium channel blocking effects at the level of the sarcolemma. These drugs have a quick onset of action as well, occurring at 30 minutes when they're orally ingested, but they only have an effect for about 4 to 6 hours, which therefore requires more frequent dosing over a 24-hour period. They are also category C, and there has been a concern that patients above the age of 60 have reported a general higher risk of drowsiness and falling injuries. And again, it's contraindicated in myasthenia gravis. Cyclobenzaprine requires a Schedule 5 prescription from a practitioner. And this is because it belongs to a group of drugs called the tricyclic antidepressants, very similar to drugs like amitriptyline. It's an antispasmodic drug that's used for treating muscle spasms and not antispastic. And again, it's ineffective in treating spinal cord or upper motor neuron pathology. But interesting is that it is a category B classification of risk in pregnancy. The side effects are also anticholinergic, and the onset of action when ingested orally is around 1 hour, with a peak effect somewhere between 3 to 8 hours.
I noticed with this drug, the neurosurgeons quite like it. Is there a reason for it?
I actually have no idea. I must say the preference of these drugs are usually individualized. And a big factor is whether it's spastic or spasmic. And I suppose by the time they get to the neurosurgeon, patients would have probably tried over-the-counter stuff maybe. So maybe what's left is the prescription drugs. But I can't imagine why the neurosurgeon would like it. Maybe.
And why would this be chosen over a benzo?
Oh, a benzo. Remember, benzos are the one that have the mixed effect, spastic and spasmic benefit, not just spasmic. So upper and lower motor neuron mediated pathology, not just lower mediated pathology. And very similar to the other tricyclic antidepressants, their indication for use is multimode, because it includes all the all the DSM-5 categories of mood disorder, neuropathic pain, attention and hyperactivity disorder, and muscle relaxation. And very similar to the tricyclic antidepressants, the big issue with tricyclic antidepressants is that they raise blood pressure, they raise heart rate by raising adrenaline, raising noradrenaline, raising serotonin. So heart patients are the ones that we should be wary about that are using these drugs. And this, again, is once a day a dosing at a dose of between 5 and 15 milligrams.
I think just to take you back there about our patients with heart diseases, I think as physios, this is a very important physio implication, because when we do an exercise therapy and we know that they're prone to any heart conditions, arrhythmias, we have to be extra careful with what we prescribe and how we prescribe it.
And very important, because you're going to take their heart rate up with the physical activity, and this is going to aggravate it even more. Okay. Now, going to something that's readily available over the counter, Schedule 0 magnesium. Magnesium is so accessible because it is one of the 4th most common cations in the body, next to sodium, potassium, and calcium. And it is so beneficial that it's actively involved in multiple activities, from heart function to muscle function, serves as an antioxidant in inflammation. It neuroprotects the brain. It serves as an analgesic by NMDA receptor antagonism. It's a factor regulating the clotting cascade, and it's a fundamental factor in bone physiological health.
So you're mentioning that this is a Schedule 0. So as physios, would we be able to at least recommend it to patients?
Absolutely. But remember that when you're recommending it, you should recommend it at the recommended maximum daily dosing allowance. And if you're not sure what that is, read it on the side of the pack. I mean, I struggle. Patients come with so many different brands of magnesium citrate, magnesium glycinate. I actually just ask them to bring it to me, then I can read the package for them. So if you are prescribing higher doses, one should be assessing the magnesium level in the blood at least every 6 months.
And you mentioned, when you mentioned, you said magnesium, you said potassium, and you said sodium. But potassium is very different. The only time we would ever suggest it is when we say, eat an apple to keep the doctor away, eat a banana to keep the physio away, right?
Well, I mean, in a hospital setting, potassium is kept under lock and key, because for those of you that watch those American thrillers where they're on the death chair, the recipe for the death chair is you get a benzodiazepine to take your memory away, you then get a muscle relaxant to stop your muscles from working, and then you get injected potassium to say bye-bye, because the heart stops with high potassium. So we shouldn't be recommending actual potassium supplements. It needs to come under prescription, and that needs to be assessed on monthly blood levels, not just 6 monthly. Okay. And then the most important thing to add here is that muscle relaxants are great, but when they're used alone, it's been shown that they're not as superior as using simple analgesics. But when you combine simple analgesics with muscle relaxants, their synergistic effect has been shown to be far superior in the pain response. So always consider mixing your muscle relaxant, or consider using a muscle relaxant that's already come in a fixed drug combination.
Okay, and now as physios, we know that we have so many different techniques to treat muscle spasms and spasticity, and what patients describe as stiffness. So the traditional techniques hold true. We still have myofascial release and trigger point therapy, and we know that the evidence changes, and we should be looking into it so that we are treating in an evidence-based way. But everything has its place as long as it's done in a person-centered manner. Be very aware of side effects of medication. It's important that we understand these things so that we understand physio implications, whether it's related to the deep tissue techniques that we're doing, if a patient is likely to bruise. If we put them in prone and they already have side effects related to dizziness, we should be aware that it's probably going to worsen it. If they're on a medication that causes drowsiness or sedative symptoms, we should be aware that they may be at falls risk. So understanding the indications for medication as well as the side effects is exceptionally important to our physiotherapy implications. Physiotherapy offers effective solutions for muscle spasms, but it is essential to consider that we can't just expect patients to be reliant on physio. We cannot allow them to be reliant on us as just coming to doctors for muscle relaxants and coming to us for muscle release and heat and dry needling and whatever else. We have to understand the biopsychosocial approach. We have to understand underlying lifestyle factors, their physical activity levels, and psychological and social factors which contribute to their pain experience. Often when we get patients like the one that I described in the story, it's when we're getting patients in the acute phase. They are coming in, they've just had pain for 2 days, and it's easy to fall into the step of, let me put a heat pack on it, let me dry needle it, let me do deep tissue release, let me give them a few stretches, and they'll be fine. And they may be fine. But those are the patients who come back in 3 months and 6 months and the next year and the next year. And 5 years down the line, they're the ones who end up at the neurosurgeon wanting imaging done. And they get the scary MRIs that keep saying there's massive degeneration. And then they hear the words compression. They're the ones that hear bone on bone. And that increases the fear response. This is our opportunity to treat those underlying factors, those psychological and social factors which are contributing to it. In Mr. S's story, I had mentioned that he is highly stressed. He is a CEO of a finance company, and he's extremely busy. So if we do not think of, are you sitting for prolonged periods of time? Are you sleeping well? Are you eating well? Are you actually doing strategies to manage your stress? Are you anxious and are you actually having strategies or interventions to manage this? If we do not address those things, we will be failing our patients. So when it comes to the biopsychosocial approach, we must understand the pathology. So we need to understand the biomedical aspects of it, but we also need to understand the social determinants of health. Those determinants that influence the health and well-being of our patients and influence their pain levels, influence the level of muscle spasm that they may have. Why is there muscle spasm? What is it protecting and why? We need to understand the psychological and social factors. And yes, as physios, we may not be fully equipped to treat this, but we need to understand how to screen it and how to realize, oh, this person needs to go to a psychologist. This person needs an OT. This person needs interventions beyond just what I'm giving now. We need to be able to see a little bit into the future. We need to not just see a person who came in with 2 days of neck pain that I most likely can fix this week. And then what happens? When it comes to pharmacology, we need to understand the pharmacology and we need to understand what has been prescribed, as I've mentioned, for implications of this to your treatment. But also as physios, we need to feel empowered to actually speak to prescribers and to speak to doctors. Often we know way more than a doctor knows. We may understand contraindications that they never even mentioned to the doctor.
But
Hey,
remember,
Dr. Naidoo,
Laeeqa, you are spending 45 to 60 minutes,
a week.
whereas I see them maybe once a month for 20 minutes as a specialist. So you are getting so much more collateral history. So I think it's important as physiotherapists for you to own with confidence that information, because very often you do know more about the patient than we would ever know. And so it's important that sometimes if we miss something to go, yo, dude, you forgot this lady has X, Y, and Z, and you've given her this drug. So don't be afraid.
Yeah, picture that a patient is going to a neurosurgeon. There's a possibility they're not going to tell them that they have glaucoma because this is the doctor who's looking at my spine. Why would I tell them about my eyes? But you as a physio know this. We know the names of our patients' pets. We know where they go on holiday and where their holiday houses are. We know the names of all of their children and probably where they go to school. And so we should feel empowered.
Your patients have holiday houses.
We should know these things and we should feel empowered to speak to the doctor. We're not going to tell them, do not prescribe this drug, but we should feel that we can actually have this conversation with the doctor to understand it. And they often do have a reason for why they prescribed it, but it's important for you to understand it. One of the biggest factors in a biopsychosocial approach is actually having an interdisciplinary team. You need to be working together to reach this goal of the patient, the same goal. And patients can sense when there's tension between a physio and a doctor, and it affects the relationship. And it affects the relationship either between you or between you and the doctor, between you and the doctor, or between them and the doctor. And that itself influences their pain response. So actually working within a team and speaking to doctors about these things is exceptionally important. Don't take it for granted. Hey, so what exactly are we comfortable with telling patients? Speaking about medication can be challenging, and it is a bit of a gray area. How much can we tell them? How much should we tell them? Please go back to your doctor and ask. Where do we actually draw our limits? And what can we ethically tell them within our scope of practice? I think these are very ethical based questions that we should be thinking about and we should be speaking about more in our circles to know that we are ethically practicing and always having our patient's best interests at heart.
I think maybe to chip in, it's useful to actually start with a disclaimer. I am not a prescriber and I haven't studied extensive pharmacology, but I do know that this drug can do this or can cause this. So if you're going to start with a precautionary disclaimer, I think you are encouraging the patient towards information that they would have not easily had accessible. So maximize on the time that you have because you are a fountain of knowledge. And just like that, we've come to the end of this presentation. I hand over back to Adele. Maybe we should ask Monique to take over.
Yes, I'm online. Yes, I see there's a couple of questions. Of one from Bruce Barker. He says, "Thank you for your presentation. It is well known that medications can have painful muscle-mediated side effects. Examples include antimalarials, retrovirals, and statins. Please, could you comment on the myopathic side effects of statin drugs and the use of CoQ10 as a possible countermeasure?"
So the statin drugs, a massive side effect is that they start activating a path of muscle cell breakdown. The word of this is called rhabdomyolysis in the extremity. So every now and then a patient would have an extreme version of rhabdomyolysis that will result in all these muscle breakdown molecules causing kidney failure, and it can be extreme. But similarly, it causes some form of inflammatory response to the muscle, which results in in pain. The statin effect is dose dependent on muscle. So you'd find that at low doses, the patient might not have any muscle pain, but at higher doses, they will suddenly have it. It's important to differentiate between a risk and a side effect and graded responses from side effects. So I always tell patients, if you didn't have a response at 10 milligrams of atorvastatin, but you're having a response at 40 milligrams, just go back to the 10 milligrams because it isn't an absolute contraindication unless you have confirmed rhabdomyolysis. In that situation, it's absolutely contraindicated. As to the benefit of the Q10 molecule, that I must actually admit is outside the scope of my practice because Q10 is what we call a nutraceutical. So it's something that one can acquire over a herbal section in the pharmacy. And so the factors with these molecules is that they don't undergo randomized controlled trials and or meta-analysis. So I will reserve any opinion that I have on the Q10 interaction in muscle protection, hint, hint, nudge, nudge, on the mechanism it might have.
Thank you, Dr. Ruben. Bruce is, just a disclaimer, Bruce has actually got inside information on HPCSA, and he says, regarding your open discussion slide, precautionary disclaimer is good. Scope of profession for physio at present does not include subscription, but we are working on it. To include prescription in your personal scope of practice will require the successful completion of an appropriate prescription training course. So they are working on physios in South Africa getting prescription rights too.
So it's exactly what's been done in the UK. They've developed a whole separate academic program to validate your ability to prescribe. the same program has been transposed into the application in Australia.
In Australia, yeah. We actually spoke to the guy from the UK. And yeah, so there's massive talks at our Congress in September last year regarding it. Yeah. So yeah. Any other questions from the audience? I see one just popped up now. When is ketamine prescribed?
So ketamine is a drug that works on the NMDA receptor at the level of both the spinal cord and the brain. And it works by multiplicity of mechanisms that have pure analgesic effects, neural modulatory effects that enhance neuronal plasticity, anti-inflammatory effects, effects that contribute to mood stabilization, and the current massive indication that's been approved is for severe refractory post-traumatic stress disorder. And my favorite story to tell is there was a massive case in the New York Supreme Circuit a year and a half ago, where the patient sued the psychiatrist because after he left the session with the psychiatrist, the patient attempted suicide. And he clearly was alive to then sue the psychiatrist, but he sued the psychiatrist saying that you knew I was parasuicidal, you let me walk out of your room, and you didn't give me ketamine. And so when the judge listened to the story and he looked through the evidence, so legal assessment of a case looks at a beyond reasonable doubt, and in a science case, in overwhelming scientific data that validates it. And he actually found that the patient had a valid argument. If he knew he was parasuicidal, he should have been given a bolus of intravenous ketamine and it would have alleviated his suicidal ideation. But luckily, the patient lost the case because the psychiatrist made beautiful notes, and nowhere in his notes at that assessment was he suicidal, so parasuicidal. So he might have been parasuicidal when he walked out the room, but not during the consult. And so the case was lost in favor of the patient. So
Yeah,
again, I
very
think in the
interesting.
muscle spasm realm, remember patients with mood disorders have lots of built-up tension because of all their electrical and hormonal imbalances. So mood disorders have muscle spasms. So maybe in that situation, ketamine might be a useful agent. But currently, the only indication for ketamine registered in South Africa is for refractory mood disorders. And mood disorders refractory to conventional medical therapy.
Okay. But in the UK, is it different? Are they using ketamine as part of chronic pain regimes?
Yes. So in the chronic pain realm, we've been using ketamine since, sorry, you got on one of my favorite topics now.
Sorry.
Since 1971 in anesthesia, and it's formed the basis of our education in anesthesia as an induction agent. And through the years, we realized that microdosing of ketamine offered sustained benefits to patients who had long-term pain. It's been studied in chronic pain conditions like neuropathic pain, fibromyalgia, complex regional pain syndrome. And the evidence is quite scanty for the individual conditions, but there is category B evidence in the neuropathic pain disorders. And some studies say category B for fibromyalgia and complex regional pain. Some say category C. But again, the problem with ketamine is we don't know how much to give. We don't know how long to give it. And the major meta-analysis and systematic review was done in 2019, from which a lot of the my practice guidelines come from. But the problem there is that every study included, all the randomized controls included, had heterogeneity in their dosing regimes. So take-home story is we don't know how much to give for how long, but we do know that in theory, the smaller the dose, the longer you have it for the use, it has a beneficial use in chronic pain disorders. And as anesthetist, I can only comment on chronic pain. I cannot talk about the mood disorders.
And I think it's important when we prescribe this, it's so important to work in an MDT, because what happens is when Dr. Naidoo prescribes it, I do baseline outcome measures before he actually prescribes it. And then we try to monitor if there's actually an influence directly to the ketamine. Specifically, we've been seeing if there's a difference in central sensitization. So we've been using the CSI as an outcome measure to actually see a difference. Maybe one day we'll do a study and see if they.
Fine. And then there was a follow-up question to the ketamine and in spinal strokes. Are you guys using ketamine in spinal strokes?
So there's no evidence really for spinal strokes. It's very hard. And the only drug that's really useful in spinal strokes that has the strongest evidence, even though it's weak evidence, so strong as a relative word, is the tricyclic antidepressants. So most of the research has been done on amitriptyline in central stroke and spinal stroke patients. But watch the space because the new NUPSIC neuropathic pain guidelines are going to be published anytime in the coming days, hopefully weeks, but it's definitely in print. So it will be published soon. And there's been some changes from the 2015 guidelines in the favorability of drugs. So previously, the gabapentinoids like pregabalin and gabapentin were favorable choices as first line. But current research suggests that the noradrenaline serotonin reuptake inhibitors in combination with the tricyclic antidepressants together offer a 65% greater positive effect on neuropathic pain as opposed to the gabapentinoids alone. So watch the space. This will be coming out any minute now.
Dr. Ruben and Laeeqa, thank you so much. I'm sure everyone enjoyed the role plays with Dr. Ruben being the patient, and the interaction between you and Laeeqa made it so enjoyable to watch and listen to. And the hour rushed by so quickly. But most important, thank you for sharing valuable knowledge with us. On behalf of Inova, thank you once again to all parties involved. A special thanks also to Monique Koopman, the Deputy President of the South African Society of Physiotherapists, and Esther Venter, the Junior Professional Officer, who I'm sure everyone knows, working closely with us and marketing an event for the Society tonight. Just a reminder, you will need to either have attended the live webinar or listen to the recording and complete the CPD questions to receive the 2 CPD points for the event. And with that, good night and have a good rest of the evening.